Welcome to this video tutorial on AV heart blocks. A heart block is an abnormal heart rhythm known as an arrhythmia that can occur anywhere in the specialized conduction system of the heart. The electrical signals telling the heart to contract are partially or totally blocked between the atria and ventricles. Therefore, it is known as an atrioventricular or AV block. A normal heartbeat is initiated by an electrical signal which starts in the sinoatrial or SA node, the heart's natural pacemaker located in the right atrium. The impulse travels through the atria, moving down to the atrioventricular or AV node, located in the center of the heart between the atria and ventricles. The AV node functions as a critical delay in the conduction system, preventing the atria and ventricles from contracting at the same time, which would cause an ineffective flow of blood through the heart. The electrical current travels from the AV node to the ventricles, causing the ventricles to contract and pump blood out to the body. In a patient with an AV heart block, the electrical signal controlling the heartbeat is partially or completely blocked from reaching the ventricles. Heart blocks may be congenital, they may occur secondary to medications, or they may be caused by a disease that results in tissue death, affecting a portion of the conduction system. As a person ages, the risk of acquired heart block increases, along with the incidence of heart disease. The most common cause of acquired heart block is a heart attack, but may also be caused by an enlarged heart, heart failure, and rheumatic fever. AV blocks are identified by their severity: first degree, second degree, which can be subdivided into type 1 and type 2, and then third degree heart block. Organizing heart blocks by constant versus variable PR interval can help you separate one heart block from another. The heart blocks with a constant PR interval include the first degree and second degree type 2 or Mobitz II. The heart blocks with a variable PR interval include second degree type 1 or Winkie-Bach and third degree. First degree AV block is the most common heart block. It occurs when the electrical impulses are slowed down, but they still successfully reach the ventricles. On the EKG, the PR interval represents the measurement of conduction time between the atria and ventricles. First degree heart block will look like a typical sinus rhythm with a constant PR interval. However, it will measure greater than 0.20 second, when it should normally be 0.12 to 0.20 second. This indicates a conduction delay in the AV node. The rhythm is always stated in the interpretation. For example, sinus rhythm with a first degree AV block, or sinus bradycardia with a first degree AV block. First degree heart block is often seen in highly trained athletes, and when occurring in isolation, the patient is usually asymptomatic and no treatment is necessary. It may also be found in association with rheumatic fever, acute inferior MI, increased vagal tone, and AV nodal blocking drugs such as digoxin and beta blockers. Second degree AV block occurs when there is intermittent conduction failure and can be broken down into two categories: type 1, also known as Mobitz I or Winkie-Bach, and type 2, also known as Mobitz II. In Mobitz I or Winkie-Bach, the electrical impulses are delayed further and further until conduction fails to reach the ventricles entirely. Malfunctioning AV node cells progressively fatigue until they fail to conduct an impulse. This is characterized by a PR interval that progressively gets longer and longer until the P wave is not followed by a QRS complex. The QRS has dropped off after the P wave. Essentially, the heart has skipped a beat. Any drug that slows AV conduction may cause a type 1 block, such as beta blockers, calcium channel blockers, digoxin, or amiodarone. However, these blocks are most often seen in patients with an inferior MI, increased vagal tone, electrolyte imbalance, myocarditis, or following cardiac surgery. Mobitz I blocks are usually transient and reversible, not requiring treatment unless the patient becomes symptomatic. Atropine may be effective in increasing cardiac output in symptomatic patients. Second degree type 2 or Mobitz II heart block is less common but more serious. In this type of heart block, some of the electrical impulses do not conduct from the atria to the ventricles at all. There is a constant PR interval, but random QRS complexes are missing. The QRS complexes may occur in a specific pattern in a ratio with the P waves, often referred to as a 2-to-1 or 3-to-1 block, depending on the ratio of P waves to each QRS complex. Or the QRS complexes may occur in a more unstable, unpredictable manner. Either way, this is a much more serious dysrhythmia and can potentially convert to a third-degree heart block. Mobitz II is usually due to structural damage to the conducting system below the AV node in the His-Purkinje system. This may be seen with myocardial infarction, fibrosis of the conducting system, inflammatory conditions, cardiac surgery, especially when close to the septum, autoimmune disease, hyperkalemia, as well as drugs such as beta blockers, calcium channel blockers, digoxin, and amiodarone. Mobitz II is likely to be associated with hemodynamic compromise, which may be sudden and unexpected, causing syncope or sudden cardiac death. If cardiac output is decreased, a temporary pacemaker can be inserted until the conduction stabilizes. However, if the block is persistent, the patient will benefit from a permanent pacemaker. Third-degree heart block is a complete heart block in which none of the electrical impulses from the atria reach the ventricles, so the atria and ventricles beat independently. The ventricles may generate some impulses on their own, called junctional or ventricular escape beats, but at a rate much slower than normal. On the EKG, the P waves and QRS complexes are seen regularly, but at two distinctly different rates because the atria and ventricles are beating independently of each other. The causes of third-degree heart block are the same as for Mobitz I and Mobitz II, the most important ones including inferior MI, AV nodal blocking drugs such as calcium channel blockers, beta blockers, and digoxin, and degeneration of the conducting system due to unknown cause. Complete heart block is essentially the endpoint of either Mobitz I or Mobitz II AV block. It may be due to the progressive fatigue of AV nodal cells, as in Mobitz I, or it may be the result of a sudden onset of complete conduction failure throughout the His-Purkinje system, as in Mobitz II. Patients with third-degree heart block feel poorly, with lightheadedness and fatigue, with a high risk for sudden cardiac death, especially if it is accompanied with an anterior MI. Urgent backup temporary pacing is required, as well as the insertion of a permanent pacemaker or defibrillator. Now for a brief review of AV heart blocks. A heart block is a partial delay or complete interruption in the conduction pathway between the atria and ventricles. The electrical signals telling the heart to contract are partially or totally blocked between the atria and ventricles, an atrioventricular or AV block. AV blocks are identified by their severity: first degree, second degree, and third degree. First degree is not a true block, but a consistent delay of conduction in the AV node, resulting in a PR interval longer than 0.20 second. The electrical impulses are slowed as they pass through the conduction system, but they all successfully reach the ventricles. This type is relatively common and treatment is generally not needed. Second degree Mobitz I or Winkie-Bach is an intermittent block at the AV node. The electrical impulses are delayed further and further with each heartbeat until an impulse fails to reach the ventricles entirely. This is seen on the EKG as a PR interval that progressively lengthens until a QRS complex is dropped. Therefore, there are more P waves than QRS complexes. Second degree Mobitz II is an intermittent block at the bundle of His or bundle branches, resulting in some of the electrical impulses not transmitted from the atria to the ventricles at all. There is a constant PR interval, but random QRS complexes are missing. This condition is more serious and will likely require a pacemaker. Third-degree heart block is a complete block at or below the AV node in which none of the electrical impulses from the atria reach the ventricles. The atria and ventricles beat independently of each other. Urgent treatment is required. Ultimately, a permanent pacemaker or defibrillator will need to be inserted. Thank you for watching this video tutorial on AV heart blocks. Be sure to check out our other videos in our heart series in the description below.